All right, ladies and gentlemen, thank you so much for being here today. My name is Michael Usher. I'm a proud ambassador for NECA and have been for a few years. We're here today because in April this year, there was a very important Senate inquiry that came back with 41 recommendations in relation to funding and support in the area of NETs and this very rare condition. So we would like to try and spread the message. We need the government to close some of the gaps, to support more of the recommendations. They've supported many of them, but some more action needs to be said. So we're here today to make a little bit of noise about this cause. I should also acknowledge just from the very get-go the traditional owners of the land, the Ngunnawal and Ngambri peoples. We certainly respect and honour their elders past, present and emerging. We've got a wonderful panel of people today, so we thought we'd run it as a Come on up. We thought we'd run it as I'll guide some of the topics from the beginning and certainly open up to some questions at the very end as well. We find this topic and these rare cancers certainly generate a lot of discussion, and there's certainly a few questions at the end. So we've got experts and patients, but I'll introduce them all as well. The basic premise of us talking here today is that in April this year, there were 41 recommendations in a Senate inquiry about what to do in these areas, and there are gaps. There are some recommendations that have been supported by the government, others that have simply been noted, but we'd like to close some of those gaps and get some action going. So more people will talk about that in detail. But on our panel today, we have coming along shortly Senator Wendy Askew, Liberal Senator for Tasmania, strong advocate for health equity and particularly regional access and cancer care improvement. Liz De Soma, thank you for coming, the CEO of Medicines Australia, expert in health policy and HTA reform and a member of the Implementation Advisory Group as well. Professor Stephen Clarke, medical oncologist and clinical researcher, and a leading voice on access to emerging therapies and trial participation. Meredith Cummins, the powerhouse CEO of NeuroEndocrine Cancer Australia, a national leader in advocacy, patient support and equitable cancer care reform. The recommendations in the report she's a full bottle on, so she'll know the ones to target today and get the message across. Therese Townsend, a patient advocate living with MEN1. There's a lot of acronyms today, you'll hear them all, and I've got a guide in the back of my notes here. I won't go through them, but the experts will tell you what they all mean. That's the best way to do it. Therese, thank you for being here today, and also Raynor, a patient advocate with AdvanceNet, experienced overseas genomic testing. She knows the difficulty that patients go through to get the right care, and certainly going to highlight the costs and the inequities as well. So Lauren will have a talk about that. Thank you all for being here today. I might introduce first, if you don't mind, we have Rebecca White, the Assistant Health Minister today, saying a few words on behalf of Mark Butler, the Minister. So Rebecca, I might ask you to come up and say a few words. Thank you very much.
Good afternoon, everybody. You're all spread out quite far around the room. I'd first like to pay my respects to the Ngunnawal and Ngambri people on whose land we are gathered this afternoon, and to acknowledge any First Nations people who are also joining us. Thank you to the panellists for giving your time. I'm sure soon we'll be joined by more members and senators. It is always a bit tricky, I think, on a Thursday afternoon. And I myself will have to leave shortly after spending some time with you because there are flights to return back to the states and territories. But I am really thrilled to be able to represent the Minister and acknowledge his advisor Jamie in the room too. So even though I won't necessarily be able to stay, there will be somebody from the Minister's office who'll be able to listen to the conversation you have and help work together on where you identify the gaps. I'm sure you'll elevate those issues for discussion today. I have been really thrilled since coming into this job to get to know so many stakeholders, but I'm very aware of how passionate and what fierce advocates you are, and particularly yourself, Meredith. And I just want to congratulate you for the work that you have done and recognise those of you who made contributions to the Senate inquiry too. It did have a number of recommendations, which the panel will explore in a bit more detail today. But of those 41 recommendations, the government is formally supporting or provided in principle support to 31. Some of those recommendations fall within the areas of state and territory responsibility or require federal-state collaboration. And the ministers asked the state and territory health ministers to consider these recommendations, and the department is continuing to consider the more complex recommendations. And I'm sure that you might touch on those in your conversations on the panel today too. But I want to reassure you that work is happening on the recommendations that have been agreed to, and that includes through a range of investments and programs demonstrating our commitment to improving outcomes for people with cancer, regardless of the tumour type or locations or in which they live, or their income, or their ability to engage with services, which can be a challenge for people in rural and regional areas, First Nations and other diverse backgrounds. One of the things that I've found most exciting about developments in medicine is genomics and the research that's occurring, and particularly the focus on personalised medicine, which is improving outcomes for people with rare and less common cancers, and has been a significant focus for our government. One of the values that underpins our efforts in this space is to deliver more equitable access to diagnosis and treatment, and faster and fair access to therapies. And genomics really does help us to harness that power. And so in March this year, the government announced more than $143 million to extend 2 world-leading precision medicine programs, almost $31 million to a program that Omicron is delivering, which is the Prospect program, which allows free comprehensive genomic profiling for patients with advanced, incurable or poor prognosis cancer, and then matches them to suitable clinical trials, which opens doors to otherwise inaccessible new therapies. And we've also directed more than $110 million to expand the Zero Childhood Cancer program. So this is for children with cancer and more young people to ensure that they can obtain genomic analysis and precision oncology. And there's also a significant amount of money being invested into research into rare cancers, including $6.7 million for the Australian Rare Cancers Portal, $150 million in a new 10-year low survival cancers mission, and $62 million in research grants as part of the MRFF's Clinical Trials Activity Initiative, which includes into treatments for rare cancers. There's been significant investment in the workforce that's supporting people living with cancer through the Cancer Nursing and Navigation program. I'm sure that you're here in this room because you're touched in some way by cancer, or somebody who's been going through that experience if you've been supporting them as a patient of your clinical service. And being able to navigate healthcare at a time when you're dealing with immense stress can be quite challenging, and our effort to support patients and families really is underpinned by making that a little bit easier. So we did announce earlier this year, as part of Australia's Cancer Nursing and Navigation program, that the Mark McGrath Foundation will be supported to recruit 100 new cancer nurses, resulting in over 300 Commonwealth-funded cancer nurses by 2027, and they will be supported to help people regardless of their tumour type, expanding from just being breast care nurses, where they're so well known and have such fabulous reputation, to support other patients living with different cancer types. And I am also delighted that NeuroEndocrine Cancer Australia and Rare Cancers Australia have also been funded under this program to deliver specialist support, both practical and emotional, to patients, their families, carers and friends impacted by these cancers. You spoke about some of the changes that have happened in the 12 months since this group came together, but including in that, I just mentioned 2 weeks ago, the government announced that more Australians living with advanced cancer could have access to immunotherapy treatment options, thanks to new recommendations from the Independent Pharmaceutical Benefits Advisory Committee. So PBAC has backed listing Opdivo, did I say that right, Meredith? Mm-hmm. Great. And Yervoy on the PBS for a wider range of advanced and metastatic cancers. It also recommended the expansion of these medicines for retreatment of the same cancer for longer use where a patient is likely to respond to it. And the department's now working closely with BMS Australia to ensure that all necessary listing requirements are met to progress this medicine to PBS listing. Now, this move is the culmination of years of collaboration between the government, the department, PBAC and sponsoring pharmaceutical companies, and I just want to congratulate everybody involved in that, because it does take quite a lot of effort, sometimes a lot of time, to progress the listing of these medicines, but it can be transformative and life-changing when it occurs. Our government's made a significant investment in providing cheaper medicines to Australians, and from the 1st of January that will become even more affordable, with scripts on the PBS going down to $25. We want to make it easier for people to access the healthcare that they need and increase equity of access for Australians no matter where they live. I'll finish my remarks there, but just wanted to close by saying thank you for the effort that you've put in on behalf of patients who've got rare and sometimes incredibly debilitating cancer types, and the work that you did through the Senate inquiry as well. I'm very sorry I can't stay for the entire discussion today, but we've got spies in the room who will feed back to me and to others to make sure that the conversation that's had here today helps inform decision-making of government. Thank you so much.
Rebecca, thank you. We know your time is precious, so really appreciate you being in the room, and I've got no doubt that Meredith will continue to pursue you down the track as well and make further points. And on that, let's introduce Meredith Cummins, the CEO of NECA, to the microphone. Thank you.
So thank you so much, and I pay my respects to the traditional custodians of the lands that we're meeting on. So I just thought I'd set the scene about what neuroendocrine cancer is all about. And the main purpose of neuroendocrine cancer is to support and educate and advocate for patients with neuroendocrine cancer. And we want to make sure that we do get a lot of education out to not just patients, their carers, general public, but to healthcare professionals as well, because all too frequently it's a cancer that is, it's not actually a rare cancer, it's actually a cancer that is 7th most common, despite it not being listed on the rankings with Australian Institute of Health and Welfare. But the incidence of it is 21 per 100,000, and there are 31,380 patients living with neuroendocrine cancer in Australia. And in the last year, there were 5,719 new patients diagnosed. So as you can hear, the numbers are not small, and it is a cancer that really, really needs to have a lot of attention given to it. So with Neuroendocrine Cancer Australia, we have nurses, which we've been able to increase the amount around Australia with the Australian Cancer Nurse Navigation Program. And with that as well, we've been able to put on dietitian, who is on every Monday and alternate Friday, and a counsellor 3 days a week. All these services are free, and so they've been really heavily booked, and the patients are getting so much benefit out of it. Plus the fact that we've got nurses in nearly every state now, and so we've got the telehealth line that people can ring and get the assistance, and also to be helped with navigating the system. It's not an easy thing to do. With the McGrath nurses, we've been fortunate to have one nurse put in dedicated to neuroendocrine cancer in WA. We're hoping to have more nurses who are going to be just dedicated net nurses, and Tasmania is on our radar at the moment, but we do have the all cancer nurses, but the only issue that we're finding so far with the all cancer nurses is that they are all cancers, but they're actually being requested to look after about 3 specific cancers. So there is the issue that there could be a gap, and neuroendocrine cancer is not one of the cancers that are going to be given to the all cancer nurses. Within this event today, we're going to be talking about the ban for discrimination for insurance, and also further access to MBS and PBS listings, and expanding criteria, especially for novel medications and trials. And we'd really love to see dedicated funding go to neuroendocrine cancer, because there isn't much money that's going towards it. A few years ago, we were told that there was 73 million that was going to neuroendocrine cancer over the last 10 years. When we looked into that, it was only 8.5 million that had been dedicated and given to neuroendocrine cancer. The other 65 million was to neurological cancers, which is the brain. So it had been miscalculated and misreported. And so we want to make sure that that doesn't happen any further. And also, Liz is going to talk with the HTA reform, and I am involved also with the Bridging Fund, which I know Liz will possibly enhance a little bit more, but it's looking at additional funding for drugs when they're not actually on the PBS. So just a few other facts is one Australian is diagnosed with neuroendocrine cancer every 90 minutes, and on average they wait 5 years before they get a correct diagnosis. 30% of patients are diagnosed in the emergency department, and most of that is incidental. There's a lot that come through as appendix, and when they've actually done the appendicectomy and they've sent it to pathology, about 50% have got neuroendocrine cancer patients in it when they've been presented to ER with appendicitis. 1 in 49 patients has a chance of developing a NET. 1 in 2 patients is diagnosed with something different, which is normally irritable bowel, menopause, asthma, because they get diarrhoea, abdominal pain, wheezing, flushing. So it's very easy for GPs to misdiagnose, but we want to make sure that if anybody has got those sort of symptoms, that they actually think, let's look further. There is an amazing law that they're hoping to pass in the UK called Jess's Law, and she was a young lady who had cancer. It wasn't a neuroendocrine cancer, but she had continued to go back to her GP and it wasn't diagnosed. She actually died from it. So what they're saying is strike 3, let's start thinking about something else so that you're not just continually going to a doctor. GPs that I've been speaking to, they've all turned around and said, they've never seen a neuroendocrine cancer patient. Well, they would have seen a neuroendocrine patient, but they didn't diagnose it, and that patient got frustrated and moved on to another doctor. So 1/3 of patients report that cost is a consideration when it comes to choosing a cancer treatment. And the last final stat is 60% of our patients have stage 4 disease by the time they're diagnosed, which means they're no longer curable. So earlier diagnosis, more education of healthcare professionals, more education of the general public. Hopefully we can get earlier diagnosis and get a cure for our patients. So thank you.
Thanks, Meredith. So we may just get into the first area. There's a few topics we've broken it into. The first one being government accountability and diagnostic access. So a couple of the key recommendations in the Senate inquiry that came out in April relate to urgent referral, diagnostic reimbursement, and an important one of MRI and PET access as well. Lauren, I might start with you. Just your experience as a patient in this space of, very well the out-of-pocket expenses involved in the treatment, but also access to these important scans. Give us your experience of the difficulties in those areas.
From my experience, I was already diagnosed very late. So it was stage 4, grade 3. So it was all through my body. So I actually had relatively quick access to those scans. But Tassie being Tassie, we've only got 2 PET scans in the whole state. 2 PET scan machines, sorry. So the wait for a PET scan, even urgently, is usually multiple weeks. And that's an urgent scan. And for treatments, there's only so many limited treatments that are approved on the PBS for my type of neuroendocrine cancer. Again, like all rare cancers, because there isn't as much clinical trials and research into them, then there's less treatment options that are approved on the PBS. So you're not only is it a rare cancer, but then you're already behind like the game of chemotherapy and treatment options because it's so rare. Whereas like the more common cancers have more clinical research and more treatments out there, so their outcomes are generally better as well. So, but which is what happened to me. I did the standard treatments here in Australia with not a very good response, and there's not a lot of treatment options for neuroendocrine cancer.
We'll talk briefly then about the treatment you sought overseas, because we'll come back to it a little later on as well. But what have you had to do?
Yes, we'll come back to it. But so then I went over to Germany and had genomic testing over there. And that matched me with the type of chemotherapy and immunotherapy that is available here, but not on the PBS for obviously neuroendocrine cancer.
Yeah. Stephen, I might bring you in. Is it fair to say that diagnostic access is uneven, and where are the problems?
Look, Australia's actually got very good diagnostic capacity, but for neuroendocrine cancers, because they're complicated, they often require lots of scans and frequently to keep track of the cancer. So for instance, there are 2 types of PET scans we do, but we also like to do structural imaging with things like MRI scans. And they can be limited in the frequency for which they get MBS reimbursement. So I think that's why we need probably good coordination of the decision to order the treatments through expert committees that we call multidisciplinary teams. And that's been part of the problem, is we haven't had those expert multidisciplinary teams uniformly across Australia. And I think if we fix the problem of the multidisciplinary team and the expert access, I think we should be able to then line up better the testing that's required and the frequency with which they're required. So we've got an excellent system, but I think we can still refine it and improve it so that the patients aren't out of pocket for PET scans, because that can be $900 a throw if they're not remunerated on the MBS.
Is the cost of that really determining in some cases the care that patients are choosing?
More probably the monitoring and change of treatment and initial diagnosis. They're the times at which we need the really good imaging, is to get an accurate diagnosis, and B, to monitor treatment over time and to work out when we need to change therapy. So there are regular time points that we need to assess people so that we can optimise their therapy.
Therese, I might bring you in here. Sure. and your experience of diagnosing in the first place, but also the journey of going through all the scans, choosing what you had to get, or accessibility, I guess, would be a good question for you to perhaps answer. What's been your experience early on when you were diagnosed?
I might set the scene by saying I was diagnosed 25 years ago, so I was 38. And I was one of the fortunate few to be diagnosed really quickly because I happened to be friends with an endocrinologist. He sort of watched what was going on and pulled me aside one day socially. And so I was diagnosed fairly quickly, and I live in Brisbane, I'm in a capital city, so I have great access to a good MDT. That's not the case for so many Australians, and they don't even know the words MDT. They don't know neuroendocrine as a word. They don't know to find Meredith and the NeuroEndocrine Cancer Association. So I think my advocacy over the last 5 or 7 years with NECA has been trying to get people this support that NECA offers and funneling them into them. So yeah, sure, I've had 10 surgeries across the years. It's cost money. Our kids were little when I was diagnosed. They were in primary school. I went to Sydney for some of my surgeries because that's where the experts in my particular genetic condition were. So for a family that was living basically on Brian's teacher's wage, and I'd sort of pulled back from the workforce when the kids were little, fully intending to go back and further my career as a pathology scientist. Well, that never happened. So there's another cost impact. I was too busy managing my health condition, that of my kids, because it's a genetic condition. So I never resumed my career properly. So there's another, probably the biggest cost impact, I'd say. And there's also an emotional and a sense of self impact. And I guess I've found a little bit of that with NECA. I'm sort of able to use some of my skills to sort of help advocate for other patients. So.
On the subject, Liz, I might bring you in on the subject of genomics, clinical trials and access to medicines. About 7 or so of the recommendations in the Senate inquiry relate to that. The government certainly noted the need for managed access and funding models, but it hasn't acted yet. From your perspective on the HTA Implementation Advisory Group, what are the changes needed to speed up patient access to all of these?
Well, I think what we're seeing is the government in action. They have taken the very important inquiry into access to new treatments for rare and less common cancers, and where they haven't got an answer in the HTA review, they've just noted those recommendations and sort of delayed it till the HTA review gets implemented. That's being delayed by the fact that there is an implementation advisory group, and owning that, I'm on that group, which is developing a roadmap for the minister to say this is how you implement these recommendations. And in that review, which contains 50 recommendations, are recommendations that try to address some of the issues around that you're talking about. How do you get access for patients where there is inadequate data, where there is a very small patient population and there isn't a cost-effective model, where there is no TGA indication or recognised indication for that particular cancer. And one of the ways you can do that is through a managed entry program, where the medicine is made available And then as patients use it, the data is collected, and that data is used to inform a decision on continuing access. Another is a bridging fund, which Meredith alluded to earlier, where there is a decision to fund the medicine whilst all of the assessment on cost effectiveness and suitability for access is undertaken separately. And Germany has that model where they make the product available and then they work with the sponsor and the government to work out how much it's worth. So all of those recommendations are in there in the HTA review. We've just got to get them done. So we have to give the minister a roadmap. We have to get a government commitment to agree to implement that roadmap. And then we need the government to put a package in the upcoming budget so they can fund the implementation of those changes. And some of them will cost money, but some of them will be saving money. So when you think about the money that will be saved to the health system of people not having to use hospital services, not needing carers or cancer nurses, not needing all of that extra support, that will create some savings that need to be taken into account.
Stephen, is one of the problems that we miss out on clinical trials once quotas are filled in Europe, for example? And could you explain that?
Yeah, look, I think we have to compete internationally for trials. It's based on a number of things that drug companies look at, particularly the quality of the medicine, the ability to collect data, and the cost of doing business there. And Australia's pretty good with the Australian dollar as it is at the moment. But we get forgotten about because we're not ultimately a huge market long term. So we need to convince the drug companies that this is a great place to do clinical trials because the medicine's excellent, the patients are excellent, they're compliant, our regulatory bodies are pretty good. So we have to compete, and part of the way to compete is make sure the quality of the data we collect is excellent, and that will involve improving consent, involving connection with all the databases we have, births, deaths and marriages, PBS utilisation, MBS utilisation, because there's a hell of a lot of data there and we're not collecting it all together. But we also need trained staff. We train people up and they go and work in industry. So we need careers for trial staff. We need ways that they can develop through that and not be stolen by industry, and we need to train lots of people to do it. So we need to just make sure we're the first choice of industry when they want to bring new treatments in.
Liz, on that issue that Stephen raises of data, including overseas data, what HTA reforms can happen there to better support pan-tumour approvals so that Australia can access drugs that are matched to tumour profiles?
So I just want to reflect first, if I may, on Stephen's commentary, because the point that Stephen makes is that Australian companies operating in Australia are competing against their affiliates in other countries. And the problem that we're facing in Australia right now is that other countries are doing a better job of improving their systems to be as good as Australia in terms of the quality of data, the speed of the regulatory program, identifying key opinion leaders, having patient bases. And we're not doing anything extra to compete. So there are some things we need to do. There is
what would change that?
So there is the first measure that the government has funded is the introduction of the National One-Stop Shop, which is to streamline ethics approvals and also streamline some of the governance around clinical trials, because speed of initiation of a clinical trial is critical in that competition of what country you're going to do it in. So that needs to be implemented. It has got government commitment and that work is underway. But that whole pathway into market access is important. So we come all the way back to HTA. If you do a clinical trial, we have a reasonably reliable regulatory framework where a product maybe get through TGA registration, and then it languishes in our HTA system for between 1 and 3 years. And companies are going, well, if I'm going to do my clinical trial in a country where I'm not going to be able to ever get the product to market, why would I do my clinical trial there? So there's other things coming into the play there. In terms of, remind me of a question again, what can HTA do?
Supporting pan-tumour approvals.
Oh, yes.
Yeah.
So we've just seen the announcement about nivolumab and immunotherapies having a broader ability to be provided to patients where there isn't a TGA registration. And that recommendation is certainly in the HTA review, and it's certainly something that we want to really embed into the system with all the caveats associated with it, as long as it's appropriate. But there's another large recommendation about real-world data and how do you collect real-world evidence and how do you use that evidence in a systematic way that actually informs decision-making. At the moment, the PBAC will say that they will take real-world evidence into account, but it's not consistent, it's not systematic, and it's not clear what it did to the decision. How much did it inform the decision? So the recommendation around real-world evidence is quite a large infrastructure change because it will require states and territories to comply and work together, as well as the industry, in order to deliver on some kind of action on real-world evidence.
Lauren, just back on your treatment overseas, tell us a bit more about that and why did you have to go and seek that treatment?
So I had to go and seek that treatment. So my neuroendocrine cancer is a carcinoma, so it's stage 4 and it's grade 3, which means it's the most aggressive type of neuroendocrine cancer. So I was already considered end stage and palliated here in Australia. I'd done the treatments that are on the PBS here, and my tumours weren't slowing down; they were growing rapidly. And so, because I'm actually a cancer nurse myself, and I cared for a man that went to Germany, and he got an extra 5 years when we had diagnosed him palliative. So I just thought, I've got nothing to lose. I've got 3 young children. I'll go over to Germany. And so I sent my tumour biopsies over there. And then that's when they did genomic sequencing on them. And yes, we do that here. And I was because I'm stage 4, I was able to have them done here. But there was no treatments recommended to me here in Australia. And even Peter Mack, when I spoke to the oncologist there was no clinical trials either because my type of neuroendocrine is rare and so aggressive. So again, clinical trials here, there's just not the speed to get them approved and be beneficial for me. Went over to Germany and they did genomic testing on my tumours, which matched me with a chemo and immunotherapy that is approved in Australia and on the PBS, but not for my type of neuroendocrine cancer. And I also had cancer vaccines in Germany as well. And I had multiple metastases right throughout my body, and to date I have no active tumours in my body.
Fantastic. Well, congratulations. That's the best round of applause.
So it's obviously working,
Yeah.
the cancer vaccines and the treatment I'm on, even though I pay thousands every month.
Yeah.
It's keeping me alive. So, yeah.
So Meredith, I guess the question then for you is, from your perspective, why can't we do all that here? Exactly what Lauren's described.
Good question.
What would be needed for all of that to happen here?
Well, we need to have a lot more available for genomic screening, sequencing, and also having the drugs available. I mean, it's all very well to get screened and sort of find something that might be of use, but it's not available and it's going to cost you a lot of money. Yeah. I know sort of with a lot of our high-grade neuroendocrine carcinomas and high-grade NETs, they've been sent off but haven't been able to find a match. So there's a lot of issues that go with that as well, because you're having the testing done, but then you've also got to deal with the emotions of like, there's nothing that's actually available. So you're going through it with the hope that there is, but then you're told there isn't. So then sort of like, well, with Lauren, she was lucky. She was able to sort of go overseas and do that. But a lot of people can't afford to do that and don't have the capacity. And I know a lot of the time in sort of when I've been in conferences overseas, I've been with drug companies who have got all these wonderful drugs and everything, and they said, oh, we're doing global studies and global this and global that. And I've said, in Australia? And they said, no. And I said, well, how can you be global
Not
then?
quite that global. Yeah.
You just can't do that. Yeah.
Stephen, we must have the expertise and experience here to do this sort of thing. Where's the gap?
Oh, it's as was mentioned, that we just have to make sure we're pounding on their doors and the quality of the stuff we produce is good enough. Our cancer-specific survivals are 10% better than Britain, so we're we're a great place to do medicine. If your survival's already better and you're doing new drugs, you're going to get good results. So you may as well come to us. 50% of Americans can't afford any cancer treatment. So even though we're complaining, we're much better off than people elsewhere. But we need to still improve that further with some of the things we talked about before.
Yeah. On the subject or general topic area of genetic discrimination and specialist support, Therese, I might get you to recap, you told us a little bit about your story. And this is one of the acronyms, but you can explain what it is. You're living with MEN1. That's a hereditary form of neuroendocrine cancer. Were you the first in your family, or did you know it was in your
Good
genetics?
questions. They're great questions. Multiple endocrine neoplasia, type 1. So there's a few different types, but I have type 1. So yes, I was the first diagnosed in our family, and that was in the year 2000. Clearly my dad had it, undiagnosed. He died within a few years of my diagnosis. So while I'm in and out of hospital having really major surgeries, we got 3 children who needed to be screened for this genetic disease. It was a really hectic, emotionally draining time for us. So as I said, Dad had it, undiagnosed. His mum clearly had it. She died of something pancreatic when she was 40, but that was, decades and decades ago. So we now understand the line. Our children got tested when they were about 10 years old each. They're now in their 30s and they're wonderful human beings making huge contributions to society. And they've been monitored since they were about 10. So 2 out of 3 of our kids. There's a 50-50 chance with MEN1 that you're going to get it if your parents got it. So we've got 2 out of 3 of our 30-somethings who are wonderful people who are making great contributions.
Fantastic.
Yeah.
The experience of getting medical care, the out-of-pocket expenses, access to scans, what's been your experience along the way?
I think 25 years ago, having the MEN1 label actually got me into the system. Yeah. It was actually helpful. It was something that people had read about in the medical textbooks somewhere. Neuroendocrine wasn't a word I heard about till about 7 or 8, 10 years ago. I sort of went on the coattails of MEN1. That's still how my GP refers to me as. He'll often have students in his office who I'll explain about neuroendocrine cancer too, and that's great. I've been in both the public and private systems simultaneously. I've had all of my 10 surgeries privately. There never seemed to be a suggestion of doing otherwise. It's, hey, you need your pancreas out, go to this guy, he's in Sydney. He's the best. So, of course, you just make it happen, Yeah. We're on a tight single income budget with, 3 kids, and you make it happen, and then the rest falls into place around it.
Yeah. How are you today? I mean, do you have ongoing treatment?
Yeah, I've got metastatic cancer in my liver and my bones. I'm stable. I'm on a few drugs. I inject a somatostatin analogue once a month. I've had a couple of rounds of peptide receptor radionuclide therapy. That's PRRT. Had a couple of rounds of that. And I'm under the wonderful care of a multidisciplinary team in Brisbane who keep an eye on things every 3 or 4 months. And so far we're plugging along with that regime that seems to be just sitting on things. It's all there. Yeah. And I've had my pancreas removed, so I don't absorb food, and I need insulin and diabetic monitoring and all of those things. So that's a 24-hour-a-day job.
Yeah, I'm sure it is. Speaking of that sort of job as the patient manager, Meredith, give me a roadmap of where the NET specialists are around Australia, particularly in regard to nurses. We obviously don't have enough.
No. Well, I mean, the Centres of Excellence is Royal Brisbane, where Therese is. We have a nurse we have a nurse, neuroendocrine cancer nurse, who lives up there, who's available for telehealth. And there was a nurse at Royal Brisbane Hospital who was only on Mondays and Wednesdays. That was all that they were funding her for, and she's just recently taken another position. In Sydney, we have Royal North Shore, which is a European Neuroendocrine Cancer Centre of Excellence, and there is 0.3 nurse that's available at the hospital, so it's not much. And when you've got a Centre of Excellence, it should be a full-time position. We've also got Peter MacCallum, which is another European accredited Centre of Excellence. That's the only place that has one full-time nurse specialist down there. Then we've got Queen Elizabeth over in South Australia, who has a nurse who's available 3 days a week, but most of the time she's in nuclear medicine with the PRRT or lutate therapy or radioligand therapy, all the names that they have. But she's absolutely snowed under with all the work that she has there. And then over in WA, there was a 3-day-a-week nurse, which is at Fiona Stanley. But with WA, their nurses are for the whole state. It's not just dedicated to the one hospital. So they're sort of between...
Like it's small.
Hey?
Like it's a small state.
Yeah.
WA.
So Sir Charles Gardner and Fiona Stanley, we've now got a McGrath dedicated net nurse who's in that, but they only see public patients. And there's another 0.8 nurses that are available. So it's 1.8 nurses for the whole of the state. And I've got a nurse with NeuroEndocrine Cancer Australia who's 3 days a week on telehealth. So
it's woefully low, in other words.
it's pitiful, basically.
If you do get hold of the Senate inquiry, it's recommendation 21 relating to the net nurses. We need that one supported heavily.
Exactly.
Recommendation 6 is really interesting too, a suggested ban on genetic discrimination. Explain that.
Well, if you've got a genetic disorder that with the insurance, they won't insure you. So the ban, I know it's very close to, and if we've got any advisors here, it's very close to sort of having the bill passed and everything, but it's something that is so important, and there's so many families out there. I mean, with von Hippel-Lindau syndrome that we were advocating for the medication, that is a really hereditary disorder, a neuroendocrine disorder, and one family, we know of 4 generations of patients who it's gone through, and unfortunately, one of the patients had her mother, her grandmother, her mother, her elder sister, her other sister has VHL, von Hippel-Lindau. She got pregnant by accident, and her son ended up with von Hippel-Lindau mutation, and then she asked what was the likelihood of another child getting it, and they said very low. She's had another child, and that child also has the von Hippel-Lindau mutation. The patient who had the children, she is not able to have the medication that we got passed onto the PBS. She has got, well, she's had dialysis, she's had her kidneys removed, she's had a kidney transplant, and it's now failing. She can't have the medication because she doesn't qualify. She's not able to process it properly. And so it's just a matter of her sort of, waiting to see what will happen. But if
Is this Amelia?
This is Amelia.
Yeah.
Yeah. But I mean, if we've got, insurance is really important to everybody. And especially when you've got such a family history and everything like that, that any bit of money that you can get and be insured for is going to help the rest of your family.
Lauren and Therese, have you experienced this sort of discrimination with insurance?
No.
No, I haven't yet either, but yeah.
An important one to get through though, so that there isn't discrimination. That is being supported by the government,
Yes,
isn't it?
it
But
is.
It has to take a few more steps on.
Yep.
So
Yep.
that's the important part. Liz, I might ask you about funding transparency and research. Stephen, you could probably chime in on this as well. So programs like the $65 million MRFF Clinical Trials Activity Fund, they're welcome, but how can they do more to address the needs of net patients, do you think, Liz?
Well, I'm not an expert in the sort of MRF funding mechanisms, but I do think that I think there's been a little bit of media coverage lately about using the MRFF more efficiently and using more of it right now. We know that the fantastic initiation of the MRFF has delivered billions of dollars in available funding for research. And if there was at the moment, the amount of money that is released each year has remained stable. It's 650 million a year, I think. There's clearly more money available, and if more money was unlocked from the MRFF, then they could target some of the challenges that they're facing in rare diseases and rare and less common cancers. But there needs to be an action, a direct action to try and do that.
Meredith, I might bring you in there, or Steve, did you have a view on
No, I'd support that, but I also think we need better coordination of centres around Australia, and this is where telemedicine that we gained so much experience with COVID can probably come into it, because you shouldn't be denied access to a trial if you live in Dubbo and the trial's being run through Peter MacCallum. You shouldn't have to transfer down to Melbourne. We should be able to run these things nationally using the learnings from telemedicine and have consenting done such that all these centres can be incorporated into one site rather than each site have to be initiated. So we need to do some very practical things to make a study in one centre available nationally. The MRFF funding can help do that. It's been a real burn for us in a number of areas, but we need to expand that further into this realm.
Meredith, your view, because I know NECA's applied for patient support grants but been unsuccessful. I mean, what's at stake if funding for advocacy and support ends, I think it's 2027?
Yep. So if it does, and we're hoping it doesn't, I know from past experience when there has been funding gone into for other cancers, the funding actually, they've had the position up and established for a couple of years. The nurses have got a great cohort of patients they're looking after, and then the funding is withdrawn. So that nurse is no longer in that. So you've got this group of patients that no longer have the support that they deserve, and that they've been very used to being able to access. So with NeuroEndocrine Cancer Australia, up until the ACNMP, or the Australian Cancer Nurse Navigation Program, the patients were funding the service that we were providing. And if it doesn't come through, then we're going to need to revert to that. We don't want to lose any, because all the positions that we're using have put people into are fully used and are so valuable, and patients are getting so much benefit out of having the support that they need, because neuroendocrine cancers are so complex, and most nurses, and I can say that because I am a nurse and I'm with Cancer Nurses Society of Australia, most nurses don't know anything about neuroendocrine cancer. And so we want to make sure that these patients are actually getting care and support that they need by people who understand.
Liz, you would have seen a few Senate reports like this in your time, I'd imagine. What's the important steps the government has to take now? It's one thing to say they support recommendations or they note them. What actually has to happen? It can't just sit in a drawer somewhere, surely.
Well, I think we've mentioned it a few times today. It's all about money and resources. So, it's all well and good to say you support or support in principle, but then that someone has to be tasked with the implementation of those recommendations. And therefore, we would expect to see an allocation of money in the budget in order to implement the findings of that Senate inquiry. And with ownership timelines, goals and objectives, so that it can be measured to see if it's successful. But
even from just a care of patient point of view, what needs to happen out of these recommendations? What's most important to you?
Look, I think if part of the problem we have is that we're the clinicians as well as the researchers. So if you're looking after patients, you don't have a whole lot of time to put in a 100-page NHMRC or MRFF grant. So I think if we're going to do this, we need to have support from people to help facilitate all this, because there's money there, but we need access to it to benefit the patient. But we're always looking after the patient. We don't always have the time for it. So I think we need to get better coordinated. I think support groups like that Meredith's running, so that we can work collaboratively and really help the patient get access to the latest, greatest treatments in the earliest possible time frame.
Lauren and Therese, I guess it's a question for both of you. That one of the, I came on board as an ambassador under the very persistent approach of Meredith a few years ago, who collared me at an art gallery function and said, I need you on board to help us here. But part of it is messaging and actually getting people to understand what neuroendocrine cancer is. It doesn't fit well on a poster. It's not a glamorous red carpet cancer with lots of big charity events. Has it been difficult explaining to people what you both go through and what it is all about? Therese first, perhaps.
Therese first? Yes. I have been at the forefront on NECA's behalf at some GP preceptorship days focused on cancer. The annoying person at the desk, when you come out of the conference to get a cup of tea and there's somebody handing you a brochure. So I've been that person on behalf of NECA. And I've been doing it for 5 or 6 or 7 years. And initially it was, don't know what you're talking about. And at that stage we had a different name. We were called the Unicorn Foundation, and a few comments about so it doesn't exist. And just last year and this year, the response from the GP is, Yes, please, give me a brochure. Yes, I do want to sign on for that education program. I have heard of this. I do have patients, or those who don't know that they have patients, as Meredith alluded to earlier, recognise that maybe they do and they want more information. So we're getting there. And the term neuroendocrine cancer, yeah, it's a big word, but I think part of the problem is we're not associated with a particular body site or body part, and that makes it a lot harder to get your head around. My friends don't understand it. I don't expect them to. So the general public don't either, and I think that's one of our big things. Yeah.
The other thing, I think Meredith alluded to this, saying we need to cure everyone. I think we need to cure everyone. I think we've seen here, turn these illnesses, you can turn these illnesses into chronic illnesses. I equate it when I'm dealing with NET patients to being like Magic Johnson when he got HIV. Everyone thought he was going to die.
Mm-hmm.
He's still alive and contributing in society, turned into a chronic illness. And I think you don't have to cure everything. Turn them into chronic illnesses people can live with, take pills for, have injections for, and they can live good lives. And I think that's what we should be, rather than saying it's too hard to cure everyone because it's found at an advanced time. I think we turn into chronic.
Well, to your point, there's some great optimism, and particularly as we were sitting here last year discussing belzutifan going on the PBS. Now, those families, and as Meredith knows very well, that has meant for some of them no more surgeries. Like, it's incredible. The tumours have either stopped or shrunk, or and some of those cases are quite extraordinary, aren't they?
And I know talking to a few of them, because they've not had any further surgery, but they've said, I can actually now plan my life. And I know that those little gremlins are not growing because the scans are, like one of them actually sent, I think, the scans to the drug company and to myself, and sort of it was all the brain scans, and she said, look. And I mean, yeah, it's made a huge difference. And one of the guys is only 28, and he's able to do what he wants to do.
Well, and you mentioned Amelia, who was here last year as well. I mean, she lives with incredible discomfort all the time, and she's losing part of the battle, but she knows that for her two sons, there's incredible hope, and that gives her optimism as well to manage it as, to Peter's point, a chronic illness, or get ahead of some of the conditions and symptoms.
Can I build a little bit, Michael, on your point about messaging? Because obviously people like Meredith and Therese look after the messaging from patients. I don't think we have enough clinician voice calling for change and access. You know, we have great people like Stephen, but there isn't a collective medical voice saying our system isn't delivering for patients in the way that it should be. And I wonder if there's an opportunity for us to be much more in partnership. You know, obviously those clinicians who work in partnership with the industry know that there is great work to be done. But when it comes to messaging about what's going wrong, it's a bit of, I'll let the industry do that, or I'll let the patients do that. And
what are they concerned about, do you think? Why do they step
I
back?
think there is concern about being too aligned with the industry. Yeah. And I do think that this is something I'm calling out, because in these instances, the industry just wants to get patients to have access to a new or emerging treatment, whether it's through clinical trials, research, or whether it's because it's trying to be made available through regulatory and reimbursement processes. And patients carry all the heavy lifting on advocating for the need for these new therapies. Industry will anyway, but the answer when industry is advocating is, well, you would say that, wouldn't you? Because there's a commercial benefit to you. So where are the clinicians' voice? Because I think that they're very valuable, and we know that patients listen to their clinicians, and we know that politicians listen to their clinicians. We've got a parliament that's half full of clinicians, and so they understand the issues, and they do listen to their peers and their colleagues. So I do think we need a louder clinician voice.
Lauren, you'd support that?
I do, yeah. Like you were saying, I feel like politicians would pay so much more attention if clinicians were out there speaking more. Like, obviously, you're doing amazing things speaking on behalf of this panel, but not everyone is as supportive as clinicians raising their voice and trying to get that attention that we need. It is generally patient advocates. Yeah.
And you've been a great advocate, so your experience in trying to tell people what this is all about, how's that been?
Pretty good actually. But again, like we were saying, not many people understand neuroendocrine cancers, and there's so many, and they're all so different. And like you were saying, because they're not in a specific organ, people find it really hard to understand. And there's so many different treatments for different types, and what works for one doesn't work for the other. So people find that really confusing as well. But yeah, I have been trying to do more advocacy work, and I feel like slowly people are listening. But yeah, there's still such a long way to go.
Well, after Meredith recruited me, I found myself in macabre situations asking people what their cancers are in case they are neuroendocrine cancers. I had a friend who had a stomach removed, sadly, with cancer. I said, well, was it a neuroendocrine? We'd get you on board to start talking because she's a great speaker. It wasn't, sadly, but she didn't mind me asking the question, which was good. Speaking of questions, is there anyone here that would like to ask her or pose a question to any of our panellists? More than happy to take any questions at all, or any sort of further follow-ups that you'd like to know. Right over here, thank you.
Thank you all for your time. Samantha Higgins from the Victorian Cancer Biobank. Can I get whoever...
Whatever your microphone, maybe there's a microphone there? But we can hear you anyway, I'm sure.
Yeah.
So.
Could you elaborate on the role that data is going to play in sort of the emerging medical and research space, and how we can collaborate both in biobanking in the healthcare system, but also in general, the rapid advancing data that's going to impact this health sector and potentially put us all behind more steps. I resonated when you said we're not doing anything in advance and in the healthcare system. So what can we all be advocating for in the data space?
Yeah, look, I might comment on that because we're trying to do that at the moment. That's where AI, we hope, comes right into it, that you can get all the patient. We went to a meeting recently with some Americans. They reckon some of the answers might already be there, but we can't collect the data to establish it. And so we really need to get better data collection that's uniform from patient notes, from all the tests they've had, from path laboratories, from X-ray centres, how much they've spent on drugs, what were the side effects from the drugs. We need to know how long they had treatment for, whether they died of the disease or not, where they came from, what they ate, what happened to their mothers. All these data are probably available, but we're not collecting it. And so there's a whole consent issue with this as well, because you have to make sure that you consent everyone for the collection of that data to the linkage to all the government data collections. And it's just not being well done at the moment. The patients expect us to know all this. There are these single digital patient records that are going to come through that may enable us to do some of this, but we really need to sort out the consent issues, the access and the linkage so that we can collect all this data. We're doing a whole lot of genomic testing at the moment that's lacking the data endpoints that we really need to see what the implications of those genomic tests are. So we really need to improve in that area in particular.
Yeah, integrated data. My health record has been a little bit of a fizzer.
Yeah.
Integrating across interoperability across states and territories. We know that, and Minister Butler has said it on several public forums, that the health system still has the biggest use of fax machines in any other industry. That we don't talk to each other. Our data doesn't talk to each other, but it isn't digitised. It isn't up to date. So there's certainly some intention to digitise it. Don't hold your breath is really the sad state of the data at the moment. It will take an enormous investment and a lot of collaboration in order to actually get what we need, I think.
Any other questions at all?
Ask a question about the genetic aspect of it. Thanks. My husband died of neuroendocrine, and I'm interested in the genetic aspect of it, and I didn't realize that, which is important because there's a voice involved. Is it all types of neuroendocrine? So if it's not all types, how do we find out? And where do we get the people tested in the children? I'm assuming his oncologist would have that information. But I think that's really important because that, through testing, will help the kids in the future, but also perhaps will help the healthcare system. So I didn't pick up on that before. So I'd really like more information on that. So if it's only one type of neuroendocrine, then maybe it's not panic stations, but if it's all types, then that's a big concern for families.
So I might take
What is the situation?
So I might tackle that one. Not all neuroendocrine cancers are associated with genetic predispositions. So there are two types of genetics we talk about. One is that's something that you're born with and you inherit, and that can be tested by looking at things on your blood cells. The other genetic type tests we're talking about are on the tumour itself, and that might be a mutation that is making that particular cancer grow, but that's probably not something that's inherited. So some of the conditions we've heard about, like multiple endocrine neoplasia and von Hippel-Lindau disease, and there are a few others, these are inherited conditions that can be complicated by neuroendocrine cancers. But the vast majority of people with neuroendocrine cancers don't have inherited genetic conditions that we're aware of. The things that make us suspicious of inherited conditions are if there have been multiple people in multiple generations who have had the same sort of cancer. And normally if that's occurred, or in people getting cancers under the age of 40, in those type of cancers, we'd normally send them off to a genetic expert to work out if there are testings that should be done to confirm whether there is an increased genetic risk.
But how do you know if the parents, you don't have the history, but the parents or the great-grandparents or whatever?
Yeah, but usually you're aware if someone died early or what they might have died of. There are usually family stories about someone having their stomach out or dying age 39 or something like that. They're the ones that we'd really worry that there might be a genetic component.
Therese, this is what you found.
Exactly, yeah,
Family tree.
yeah. And perhaps I should have clarified that. Yeah, I do have a genetic condition, but that's by no means the rule. Yeah.
And it's only about 10% maximum of neuroendocrine cancers that are hereditary.
But having said that, we're finding out new things all the time. So if in doubt, you can always get an opinion from a genetic expert, although they're again few and far between. Yeah.
Those big wait lists.
Yeah.
I might just introduce Senator Askew, if you don't mind as well. Wendy, thank you so much for being here. We were just going to some question and answers, and we ran through a few of the topics. Wendy was instrumental in the Senate inquiry as well and getting it underway, so we really thank you for that. And is there a few words that you wanted to add? Because I was going to introduce you at the beginning, but welcome and thanks for being here.
Very much, and I really do just want to apologise first of all for being so late. Question time is usually 1 hour. It's still going, and we're now at 3 and heading to 3.5 hours before we hit a hard marker at 5:30. So I've just escaped the chamber for the first time since about 1:30, I think. So I really do apologise that I wasn't here, and I haven't actually been able to hear from a lived experience and so on today. So, but I really do thank everybody, especially for coming along and sharing today, because I know how important it is, and also how important it is for everybody to understand the neuroendocrine cancers, because it's a word that I had never heard of when I went into the Senate. It wasn't long after that I was in the Senate that I met with Rob Hammond in Tasmania, who lives near me, an hour out of Launceston. And I met with Rob, and he talked to me and actually educated me, I suppose, as an advocate about what it means to be living with a neuroendocrine cancer. It's been a long week. So as a result of that, I actually committed to him at that time that in the next Parliament, which was the previous Parliament to this, I would endeavour to get an inquiry up. So I was really proud when we could get that motion through the Senate to actually do an inquiry into rare and less common cancers, but particularly into neuroendocrine cancers. So as a result of that, there was 41 recommendations. I'm sure most of you are probably aware that this has happened, that the government only recently gave us its response, which I'm pleased to say in a lot of cases they've agreed or they've noted or they're supported or supported in principle, but we continue to work with them to make sure that, that things are actually being followed up. So in estimates, we will continue to ask those questions. That's what our role is. We've actually done the inquiry, but we don't want to just leave it there. We want to make sure that things are delivered and changed. And I was really pleased. I mean, I'm not a member of the government, but I was pleased that even throughout the term of that actual inquiry, things were actually changing. We were seeing investment in research. We're seeing commitments to nurses. Obviously, you've probably talked about the nurses here today. I'm pleased to see that even in Tasmania now we have I think I was talking to Meredith recently, that I think it's 3 days a week. That's just fantastic, because that was what Rob came to me to ask for. And that was where we started. So looking at that full circle, it's come back round, and I'm just really pleased to see that it's now a conversation that is happening nationally. I know I've been involved in the menopause inquiry, I've been in, obviously the rare cancers one, and you sort of see things in endometriosis, things just start to, once we actually start to talk about things, and it's not something we hide behind, we're actually talking about it in political levels especially, but in the communities over the dinner table. I've talked about it a lot with my family members that, would not have ever raised this topic before. So I'm just really pleased to have been a part of that, to be able to hopefully make a difference for everybody living with neuroendocrine tumours.
You'd obviously love all 41 recommendations.
I
to be
did.
adopted.
I would, dear.
But if you had your top 5, top 10 to keep the focus on the government, what needs to really...
I think a lot of it got...
That's you.
No, it's not. I know that after 4:30 there are no divisions in the Senate. No, that's the House finishing. They're part-timers, they're finished. We're going for another hour or so. There's probably a couple of main areas, not particular recommendations, but especially in the areas of clinical trials and research, because I think that was something that we really learned a lot through the course of that inquiry, was the fact that because there are such minimal numbers in Australia, it's so hard to get any sort of clinical trials up. So I would like to see that advance, and probably even beyond the recommendations, to actually be able to take consideration from global research as well, to actually be able to be considered as within Australia as potential, research that can be used for TFGA for different things, or just a lot of things that we don't actually use the information that's global enough locally. And I think that's something that I'll continue to work on as a member of the Parliament, that just to keep working in that space.
We just had a good question about data as well, sharing
Data, yes.
That's biobanking as well.
Yes.
A lot of these tumours, and they take a long time to accrue, and to do research and meaningful research, you need the consent, the associated data, and so a lot of what you're saying resonates me in clinical trials as well as biobank.
Yeah, biobank. We actually visited a couple during the course of the inquiry, so it was educational for all of us that were on the committee. We actually all came away from that committee, I think, far more better educated in not just in the rare and less common, just in cancers in general, and the research and the wonderful work that's being done by some of you in the room, I'm sure, but just the amazing things that are going on in this space. So thank you to everybody who's working in that space. Thank you for those who are sharing their stories, because it's only through doing this that we will actually be able to improve going forward.
Great. Any further questions? There was a couple of good ones over this side. Any other questions for anyone on the panel? Well, Meredith, I might give you the final say, I think, and what you want to get out of this. What has to happen? Wendy just sort of summarised some of the key broad areas that need to be worked on. You'd obviously love all 41 recommendations put in place as well. How do you want to sharpen the message from today?
I think, most important is that, there is available funding made. I will always sort of advocate for having our nurses, and having the nurses that are funded state and federally, because I know I'm sort of hitting a bit of a brick wall when it comes to state health ministers and trying to get money out of them, and they say go to the federal, and so that would be really good to be able to sort of fine tune that and have the health ministers from the states get together and get a collaborative consent to support at least one neuroendocrine cancer nurse per state. I mean, it's not
Not a big ask.
A huge amount that is able to be in the private and the public sector. So it would need to be an across sectors position, because currently there are, ones I was saying in WA, they're only able to see the public patients in the public hospitals, not across in the private. So we want to make sure all patients are getting the support. Research and clinical trials, we really, really want to see some dedicated funding to neuroendocrine cancer. There's a lot of funding going to a lot of other cancers, but I just think it would be really great if there was more dedicated funding for neuroendocrine cancer. There's so many clinicians I know that have put in their submissions and it comes back unsuccessful. And there's some amazing scientists, clinicians who are out there who are wanting to do amazing things, and they just don't have the funding for it. MBS, PBS, making sure that we've got equitable access to drugs, and being able to expand, especially
PRT therapies with different radiopharmaceuticals, and that also comes into clinical trials, because recently there was a trial that was going to start that was an alpha therapy, but it was withdrawn just before it was about to start up, and there were about 10 patients who were ready to be recruited, and it was the company's decision to streamline their pipeline and just concentrate on prostate cancer. Yeah. So radionuclide therapy, PRT, has been in Australia for 20 years with down at Peter MacCallum. It's gold standard, but we need to have more options as far as those treatments go.
All right. Well, and you do an incredible job. Meredith Cummins is incredible in what she does as the CEO of NECA, so thank you.
Thank you.
Pushing it hard every single day. One nurse is all she's asking for in every state and territory. It's not that difficult in many ways. But thank you, and to all of our panellists, thank you today, to Therese and Lauren especially, for sharing your very personal stories. Much appreciated. And hope we educated, informed, expanded. If you have any say or influence in this bigger house, push these recommendations if you can. Whoever you can get near, give it a good nudge. But thank you all for coming along and having a listen to us today. And thank you to our panellists. Much appreciated.
Thank you.